I now invite the panelists to join, uh, uh, to come on the dais to start the discussion on the same topic. Dr. Vijayakumar is our in-house pediatric pulmonologist. He's done his DM from the prestigious AIMS Institute. Dr. Neville Solomon is an eminent cardiac surgeon in India, and he works at Apollo Children's Hospital. He has done over 3,000 cardiac surgeries, and along with his colleagues, he runs a foundation called SACHI to help poor children get surgeries. And Dr. SUCHITRA Ranjith heads the PICU at Apollo Children's Hospital. Welcome, ma'am.
So good morning, everyone. So I'm also one of the odd one out here, and I briefly present about two cases which have major challenges while managing this child. So the first child was born now currently 13 months and preterm normal delivery and had distress at birth, and X-ray showed a coiling of OG2, so it was diagnosed as a case of TEF with a distal type and operated for the same on day 2 of life. The shortness was a little bit more, that is around 4 centimeter. At the same time, child also had a thrombus in the RA, and which was managed conservatively, and child was having ASD and VSD. Post-op course was a little bit stormy, and child was on ventilator for a week or so, then CPAP, then HFNC, then transferred to here after some 45 days or 2 months old. So during the first week or second week of stay here, and child had worsening pulmonary hypertension, which is hyperkinetic, so child underwent pulmonary artery banding at the time and discharged on after 3 months of life. So after discharge, every month child is getting admitted with some respiratory illness, with increase in cough, distress, and almost every month one admission which is requiring multiple nebulization, mostly due to viral illness. And at 9 months they did a upper GScopy, which was suggestive of anastomotic stricture was there in the esophagus, and the CT angio also done. That was except collapse and dilatation of esophagus, no other finding. And at 10 months of age, admitted for severe adenoviral pneumonia, where there was pandemic was going on here. Just temporary increase in the cases of adenovirus. That time child also had. And post recovery, child started to have cyanotic spells, which were multiple whenever crying. So that time the PA gradient was more. It's around 90. So child underwent the total correction of the cardiac problem, that is VSD and ESD closure, and also the main pulmonary arterioplasty was done. And then the stricture was there, which was already diagnosed by endoscopy. So stricture dilatation was done, and that time child was also found to have some hiatus, hernia was there. And post procedure, apparently the cough has increased, and the child was continuously coughing. And we thought it may be due to reflex with underlying tracheomalacia, which is going on. Then the reflex is increasing the malacia, or malacia is as some increases the reflex. So the cycle goes on. So the child is having so much of cough. So when we did a barium swallow, it suggested reflex up to mid-esophagus. We initially tried with the anti-reflex measures and thickening of meats, however it doesn't work.
Dr. Vijayakumar, we are already running short of time.
Yes,
we
sir.
have live cases. Don't present too much about the case.
Yes, sir,
make discussion more.
That's
Thank you.
So we went ahead with bronchoscopy. There was mild laryngomalacia along with severe tracheomalacia, and there was some bronchial anomaly also there, bronchial tree anomaly also there. And test didn't see any recurrent fistula. So this is the scopy video. So the larynx was a bit weak, although it is not completely closing during inspiration. So when we went into the trachea, so the initial upper part was okay. Then when we enter into the middle part, it was completely looking like a esophagus. It is flat anterior-posteriorly, and almost a near complete occlusion was there. And we looked at the fistula side, there was no leak, and we did dye test also. That was also not suggestive of any leak, recurrent fistula. So otherwise bronchus were open and there was no malacia. It's the left side. And on the right, we found that there is an absent apical segment of the right upper lobe bronchus. Otherwise, there was no malacia. So this child is having a severe tracheomalacia. So how do we proceed further? So we tried medical management as well as to address reflux. We also did a fundoplication with gastrostomy. So how do we proceed further? Sir, to Dr. now. Yes.
Thank you. The only complicating factor is we don't get to see the size of the pulmonary arteries, because there was a comment about pulmonary hypertension. I don't know whether it was after the band, after the surgery, because that's one thing I would want to see. From the bronchoscopy, it's quite straightforward. There is a significant posterior prolapse. The anterior wall is not looking any great. So my initial thought would always be this child needs a posterior tracheopexy. Definitely. Maybe to combine with an aortopexy, but I will have a look on the PAs and then decide whether that's something that I would need to consider along with that. What I tend to offer sometimes, if the PAs are dilated and cardiac correction is almost complete now, because you have done AST, VST closure, pulmonary artery has been repaired, I would join pulmonary artery to the aorta together and then move them together up. That way, the whole vascular structure, if you look at the anatomy, the right pulmonary artery is also resting on the trachea, that carena. So if you join them and then lift them together, it offers an effective vascular relief anteriorly also. The complicating factor could be the previous surgeries. 2 surgeries for the cardiac, 1 surgery for the tracheoesophageal fistula. So I will also take into account how much of additions that I will encounter. It's not a no-go. I would still put a scope inside and see, have a look how easy it is for me to approach the posterior mediastinum. Effective posterior tracheopexy can be done very effectively. That has to happen. The rest of the things depends on what findings you see.
As you said, sir, it's a severe tracheomalacia. And I have one more doubt. Even in anterior cartilaginous defect, is there any role of posterior tracheopexy before proceeding to?
There is. If you see a finding like that, if you see a posterior prolapse, which is almost, the posterior wall is coming and touching the anterior wall, but the anterior wall is not great. Anterior wall is already partly collapsing. So you could blame both, but between the two, the dominant one is still the posterior. Especially when there is a substrate of tracheoesophageal fistula, you would think the membranous part hasn't matured at all. So the posterior tracheopexy has to happen, irrespective of what else you do there.
Again, sir, we don't have any particular reference with respect to using that methacholine or pethinicol to constrict that posterior trachealis. Do you have any other idea regarding using those at least on temporary basis?
No, not doing.
I think in India we've been shying away from this since time to attack, because once in 2 months I get stuck with Suchitra with a post-op case, and we're just stuck. So, and we, it's quite simple, and I think it's an eye-opener. That's why I want you to come back for the PCSA conference also, because across the board in India, surgeons are struggling, and they've really not got aggressive about this in India yet. So
we have taken up posterior tracheopexy quite effectively for symptomatic ones, where basically our concept is simple. You show a problem, you fix the problem. So that's where we tend to differ. But if you see a problem like this, your key is getting a very effective endoscopy. If endoscopy proves that there are problems both anterior and posterior, doing posterior tracheopexy is clinically so effective. These children really do very well.
how do you size the size of that ring graft? Like, how do you decide the size?
Measure. Okay. You know how we measure the grafts, right?
Yeah.
Like that. For a neonate, for example, I would choose 8.
Okay.
And ring, because it is an external splint, the ring can be slightly bigger. We can always cut the edges. So what I do is, you take a ring graft, split it so that it's an open ring.
Right.
And then you drop it on the top of trachea.
Yeah.
I usually mark the cartilages with a sterile pen, so that I take a 5 or 6 PDS sutures and then fix the graft to that. It's an absorbable suture, but we expect fibrosis to keep the ring there itself after 3 months.
So you don't use proline?
The problem is, if I accidentally breach the mucosa, the proline remains there, keep making granulations. So I tend to prefer PDS to proline.
And your choice of suture material for the aortopexy in the
Aortopexy is proline. They're strong enough to go through the sternum. So aortopexy is proline. The tracheopexy is proline again.
Sure. Thank you.
I have a question about diagnosis.
Yes, ma'am.
Hi, I'm just asking from a intensivist point of view. Like a while ago in Melbourne, what was standard, I think it was mentioned during the previous talk, the bronchography was a very important part of treatment, and I don't, apart from This
No,
gentleman's
maybe,
talk. I'll just finish. I don't see it much. Is it just that it's old-fashioned, or it doesn't give much information? Because if you do the bronchography, you can see the segmental regions which are narrow. Moreover, I've seen, like, they put PEEP right from 2.55, 7.5. So they periodically apply a PEEP and see at what level the airways are fully open without being over distended. So of course, if it's segmental, it's not that helpful because sometimes all the pressure goes to the, to the normal areas. But when it's central and or diffuse, it's really so helpful. So I'm just wondering why it's fallen out of favor. Maybe I can.
No, ma'am. Actually, I have read only in the books, like doing a bronchogram. That too, for a medical perspective, if you see, we heard that is done for bronchiectasis to diagnose initially that bronchography, whatever. And what Sarah said for tracheomalacia and bronchomalacia, we are doing. I am hearing it for the first time. So when we see that,
I want to ask whether, in which cases would you consider that to be a part of your workup? Or maybe you can
really we didn't do worked up like that in any case.
I will put the question in another way around. How many of us do bronchogram here? One.
So one thing, we tried it in Amrita once. The problem was, we were actually with the scope and we did the bronchogram. On the bronchogram it looked perfectly fine, but then we realized that we were shooting anteroposteriorly and it was actually collapsing like this. So that's actually a misleading thing. So that's one thing that we learned.
We do biplane.
Yeah, so you have to do both sides.
Yes,
like the
we have
CM
to
has
do
to shoot
biplane.
this way, otherwise you'll miss
It's
the
like a cardiac
posterior.
cath. We have to do biplane. There is no doubt about it, and you adjust the angle according to any superimposition by any other metallic structures, any other implants, all that. So your fluoroscopy has to be custom made. Biplane is the simplest way to start.
Yeah.
We do bronchogram for almost all airway cases. Even tracheal stenosis we do bronchogram. We are still old school. Only because of the comment you made. It is so effective for us to see. And as I said, I work with a very simple brain. I just want to see the picture and determine, can I do something? Can I not do something? If I cannot do something, only then I give it back to the medical team. But then I know I have seen everything that I wanted to see. And we are still limited by the dynamic CTs and dynamic MRIs, the ability to show it fully.
Yeah.
We are getting there, but till then we would still remain doing bronchograms.
The second reason why we are not doing it, even though it is possible to do it, is doing a bronchoscopy is much simpler and easier and more cost effective than doing bronchogram for us.
Subjective element,
No, the thing is, if you want to measure the pressure, you need the bronchogram. But anyway, even if you do the CPAP and everything under sedation and all, the opening pressure, I feel, cannot be actually the same. So you can actually clinically titrate the BiPAP pressures and manage the patient and find the pressure that the patient is comfortable with clinically and manage them. I mean, even I have worked in GOSH and I've seen this opening pressures, crazy numbers. We hardly ever use those crazy numbers. At the end of the day, it's a long-term therapy.
I don't know what to do with
we
that.
use the pressure which the patient tolerates.
Yes.
And the BiPAP, I mean, especially in this case, I wonder if BiPAP was tried. At least
no, we didn't try because there was a lot of reflex, and if you give BiPAP or CPAP, again the other component will increase. So that is the second part when we do start giving this trial of NIV for this case, because they are very small, 1 year, still only 5 kg, and underwent
there is
almost
a challenge to find the interface and maintain it.
Yes.
But if we can do that, I mean, who knows, maybe this child given BiPAP for another 6 months may actually grow out and be okay. Because we have seen TF patients with similar severe tracheomalacia who are okay. I mean, this appearance that you see on the bronchoscope again doesn't translate completely to a functional status of the kid. There is a discrepancy between what you see on the bronchoscopy as well as what you see on the patient as well.
Okay, I just had one more question. Whether, I mean, a fundoscopy, a fundoplication might have helped because...
Yes, ma'am, we have already done that.
We have already done
that.
You've already done a fundoplication because
yes,
it's so
after
much
this,
of a component
after
of
this
reflux.
reflex, we found it is up to mid-esophagus and this cough is persisting. So what we did is we tried initially medical measures, but we didn't see much improvement. So what we thought is maybe we could go ahead with fundoplication and gastrostomy. That we have already done. So now again, if you see, as soon as you do fundoplication, then again the second problem rises. So how the child is handling the secretion. So there is some swallowing problem, and again there is some issue, some aspiration from above that is happening. So the malacia is getting worsened as the child is keep on coughing. So ultimately never come out of symptoms or illness. So that's the thing. So anything could have been done different, sir, Dr. Nivin, for this child over the course of time.
One question I want to ask is, could we have done instead of doing a PA band, just do the full surgery straight away? That's my approach nowadays. Even yesterday I went against my cardiologist and closed 5 ESTs and PD and came out because I thought Suchitra would do a better job with that, though the kid has airway issues.
And
in fact, that is preferable many times because it avoids the pulmonary artery dilatation. The problems with the pulmonary arteries are notorious, especially to the airways.
Agree, because the child later had this pulmonary pH, increase in pH and PA banding later.
And if I can slip in a quick question, I've had a couple of cases where you could see the left main bronchus narrowed, left-right shunts stuck on ventilator, and they're not coming off. So what would your...
We tend to do the same thing. If the bronchial narrowing is because of external compression, we would still mobilize the aortic arch and the left pulmonary artery extensively and do an aortopexy and modify the posterior trachopexy towards the bronchus, literally. We do that. That's only if you demonstrate external compression.
And this is through the sternotomy?
Through the sternotomy. If it is not, as a proof of principle, we deploy a bioabsorbable stent. The bioabsorbable stent, because it is absorbable, you don't leave behind a residue, but then it helps you to understand if it is correctable or not. It relieves. The children get extubated straight away. And then you can go back and revise the strategy. Do we need a self-expanding stent for sustainable effect, or can we repeat the absorbable stent again one more time? It gives you at least 3 months to make the other decision.
Dr. Neville.
One last question, sir. Yes. Is there any role of stenting here?
We have n number of questions to Dr. MUTHIALU Nagaraj. So we can have those questions off the dais because the next speaker is waiting in Stanford. He's going to give the talk. Sorry about it. Thank you.
Thank you.
Thank you, panelists. That
Thank
was
you.
a very intensive discussion. Thank you very much. Introducing Dr. KARTHIK Balakrishnan, who's going to talk about laryngomalacia, management of symptomatic laryngomalacia. Dr. Balakrishnan is a pediatric ENT and head and neck surgeon from Stanford, USA. He's an expert in complex surgical reconstruction of the larynx and trachea, and he has interests in improving the quality of life, safety, and value of pediatric surgical care, reducing costs of care, optimizing the patient and family. Dr. Balakrishnan is also a committed educator. He was nominated for the Otolaryngology Faculty Teacher of the Year at Mayo Clinic and has worked with Stanford residents to develop innovative quality improvement education programs. He works frequently with international colleagues to provide otolaryngology education in resource-limited settings around the world. Over to you, Dr. Balakrishnan.
Thank you very much. I am really honored to join, and I'm sorry I can't join in person, but I think it's a privilege to be here even remotely. And I see Dr. Johnson there, who's a good friend, and I'm sure we'll have a lot of useful input as well as the other panelists. So I'll share my screen, and we'll start talking about laryngomalacia. So laryngomalacia is perhaps in some ways maybe less contentious or controversial than tracheomalacia, but in some ways perhaps more so just because it is so very common and there's so many different ways to approach it. So I'll offer some insights from the literature and then some from my own practice, and of course it'll be great to learn from the other panelists as well. So, as is, I think, relevant to any of the talks at this conference, we talk a lot about the word airway, but really when we talk about airway, what we're talking about is airflow. And airflow normally should be laminar. In other words, all the gas molecules are traveling essentially in parallel. It should not be turbulent. There should be adequate volume of gas exchange, and this should be done with minimal effort. I mean, if we think about how we're all sitting here breathing comfortably without thinking about it. Now we're all thinking about it, but before that, we were all breathing very comfortably. We can move a fair bit of air without fatigue or increased effort. But so problems arise when airflow is reduced, when it's turbulent, when it requires more effort. And Usually this is due to some sort of narrowing or obstruction, and that can be static or fixed. It can be dynamic or variable with the phase of respiration. And it may manifest as noise, such as stridor, and increased effort. And when we think about managing this, especially when it comes to disorders of the larynx, we really have to think about all three of the functions of the larynx. Of course, not just breathing, but swallow and voice, because often interventions to change one of these will have some sort of impact on the other. And so there is some, in some cases, some degree of compromise or balance that has to be achieved. So when we think about, again, in children, the symptoms of airway obstruction compared to the anatomy, some of this will be very basic for some members of the audience, but I think it's important to keep in mind. Classically, we learned that inspiratory stridor ties to the extrathoracic airway. Expiratory stridor comes from the intrathoracic airway. And biphasic stridor, both inspiratory and expiratory, comes from somewhere in between. So the glottis, the subglottis, trachea, narrowing of the trachea in some cases. Wheezing is always expiratory and typically is, coming from the lower airways. And then snoring or stertor comes from the upper airway, the nasopharynx, oropharynx, and tongue base. And cough, of course, can come from almost anywhere. But the thing is, in children in particular, these associations don't always hold. And I think many of us have probably seen children who have marked distal tracheomalacia and inspiratory stridor, or they have some degree of subglottic narrowing and they have expiratory stridor and so on. So it's not entirely reliable. That said, laryngomalacia is almost universally a condition that has inspiratory stridor. And if you don't see inspiratory stridor with it, you should think of something else, or at least a concomitant condition. So Dr. Johnson will recognize this person in this photograph. This is Dr. Bob Wood, who's the father of pediatric flexible bronchoscopy, and he was a mentor for many of us at Cincinnati Children's. And he had two rules that he taught us. The first was never trust a baby. So what does that mean when it comes to breathing? Babies are able to hide severe airway obstruction in many cases with relatively minimal symptoms. Very young babies in particular do not move a lot of air. They do not have a great deal of strength to generate great effort for breathing. And so they may not move enough air to generate stridor. This is sort of akin to the child having a severe asthma exacerbation who's not wheezing. The absence of stridor can either be encouraging or it can be a very concerning sign. And so we do have to look for other findings such as retractions, accessory muscle use, and then we'll talk in a minute about some of the other associated symptoms such as feeding difficulty, etc. The other rule Dr. Wood taught us was, you not only do not trust a baby, you don't want to trust them when they're older. Because even in older children, there are exceptions to every pattern of stridor. And so it's really important to have not only a high index of suspicion for dangerous conditions, but also to have a thorough differential diagnosis in your mind. And I guess my corollary is we can't trust their parents either, because as many of us know, parents who have asthma, parents with children who have laryngomalacia, nurses, other physicians, everybody mislabels, misremembers airway noises. It's often very hard, understandably, for parents to remember whether their child has inspiratory or expiratory stridor, or if it's biphasic and what the associations are. So the history is not always reliable. So when we think about stridor in an infant, we really have to have a broad differential that goes everywhere from the supraglottis and even the tongue base, all the way down to the bronchus. But among all of those, laryngomalacia is the most common cause of stridor in infants. And then one thing, I'll just mention, though it's not really the topic of this presentation, even very young infants are at risk for foreign body ingestion, particularly if they have a loving older sibling who likes to maybe try to feed them things. So a young infant with stridor, even if they are too young themselves to crawl and pick things up and put things in their mouth, if they have an older sibling, foreign bodies should be on the differential when you're evaluating for laryngomalacia as well. So today's disease of choice, though, what we're talking about here is laryngomalacia. Many of you have seen this, but here's an example of a child with laryngomalacia. And if you can't see the video, please let me know. But here, we're doing a microlaryngoscopy, and we see, just to play the video one more time, a very curled, sort of classically omega-shaped epiglottis here. The area epiglottic folds are quite short and tight, and therefore the arytenoids themselves also show dynamic inward prolapse with inspiration, and then you overall have supraglottic obstruction, which then causes the symptom of stridor and breathing difficulty. So, this talk is going to focus on infant laryngomalacia, not some of the other more exotic variants, post-airway reconstruction laryngomalacia, sleep-induced laryngomalacia, exercise-induced laryngomalacia. Those are all things that tend to occur in slightly older kids. We're not going to talk about those today because they are less common, whereas infantile laryngomalacia shows up in everybody's practices. So laryngomalacia is a dynamic prolapse of the supraglottic tissues with inspiration. It can be associated with some static prolapse, in other words, sort of prolapse that's present over the glottic inlet with both inspiration and expiration, but there has to be some dynamic component. And it typically will create stridor and airway obstruction, and as a result, it disrupts the suck, swallow, breathe coordination in babies. The pathophysiology of it is not actually known. There are a variety of theories. One that's, I think, taken hold fairly broadly is a neurologic theory of either neurologic immaturity or potentially some sort of neural pathology. Patrick Munson and Gresham Richter published a paper in 2011 showing that there is hypertrophy of the nerves in the larynx in children with laryngomalacia. And here's a micrograph of one of those hypertrophied nerves from their paper. But we don't know really what the etiology is. And as with many airway conditions, we we don't necessarily know exactly what causes it, but we know a bit more about what to do for it. So typical symptoms of laryngomalacia, we think most about the respiratory symptoms, typically inspiratory stridor. That's worse when children are supine, when they're upset or when they're excited, and sometimes when they're feeding. And the idea there is that, if a child is crying or laughing or feeding, those are all activities that are associated with more effortful breathing, which in turn leads to more prolapse of the tissues. It may worsen with sleep and may lead to apneas and can be a cause of significant sleep apnea in infants. And in severe cases, it can cause what are now known as BRUIs, brief respiratory unexplained events. Used to be called ALTs or ABCs or dying spells, but essentially these apneic, cyanotic spells that are terrifying for parents. They often, children with laryngomalacia will often have some degree of dysphagia with coughing and choking with feeds. Again, largely because their suck, swallow, breathe coordination is not perfect. And second airway lesion is a bit of a contentious subject in the literature. So the most common second airway lesions in these children are subglottic stenosis and tracheomalacia. But the rate at which those occur is really unclear. And if you look at the literature, studies report anywhere from 10 to 80%. So it's really not a useful range in terms of counseling patients or parents, I think. One thing I will mention just as a, I guess, a style point, sometimes we'll hear people use the term laryngotracheomalacia or laryngotracheobronchomalacia. In my mind, those are non-existent diseases. Laryngomalacia is one condition. Tracheomalacia is another, and if it extends to the bronchi, it's tracheobronchomalacia. But they are separate conditions that can coexist. It is not one unified condition. Anyway, so the natural history, typically laryngomalacia will manifest in the first few weeks of life. It may worsen around age 4 to 6 months, and not totally clear why, but my suspicion is that's when children become stronger, the respiratory musculature can essentially pull air in more forcefully or at a more rapid flow rate. And that's the age at which they start to sort of feed more rapidly and suck more forcefully as well when they're feeding. Most children, it will resolve sometime between 12 and 18 months or 12 and 24 months, sometimes before that as well. So how do we treat these children? The title of the talk that I was asked to give is Management of Symptomatic Laryngomalacia. And I think that then would imply that there are children out there who have asymptomatic laryngomalacia. But I guess the way I would think about that is that they're not asymptomatic, they may be atypically symptomatic. In other words, If we look at the different categories of laryngomalacia, about 40% of kids will fall into the mild category. And when I think about how we categorize severity in this, it's not how it looks on the scope, it's what their symptoms are. In my mind, the endoscopy or the flexible laryngoscopy is a confirmatory test to say, yes, there is laryngomalacia, or no, there is not. But the severity, I think, is much more driven by the symptoms or the consequences for the child. So about 40% of kids will have mild laryngomalacia. Many of them will have stridor with no real feeding problems or only occasional feeding difficulty. But in some of these children, as I said, they may be atypically symptomatic. In other words, some of these children may have only intermittent stridor or no stridor at all, but they may have some degree of dysphagia and reflux symptoms. And just as an example, I saw a child earlier this week who was crying vigorously, had no stridor whatsoever, but when we scoped, there was clear arytenoid prolapse with dysphagia and reflux. And in my mind, that's still laryngomalacia. 70% of these kids with mild disease will need no treatment at all. Another 40% of these kids will have some degree of stridor with some feeding problems, but it's not generally a crisis. Most of them will improve over time with acid suppression therapy. And again, in these children, the feeding problems may outweigh the stridor and breathing problems in terms of their apparent severity. So again, asymptomatic or atypically symptomatic, I think they are atypically symptomatic compared to what the textbooks tell us. And then, about 20% of kids will have severe laryngomalacia with apneas and cyanosis, severe aspiration, failure to thrive, or these Bruy events, and those kids probably just need to go straight to surgical treatment. So that's the rough breakdown. This, I want to highlight this paper that came out in 2016. This is the consensus statement from the International Pediatric Otolaryngology Group. As many of you know, that group has published all sorts of useful consensus guideline sorts of statements. And this is probably one of the better laid out summaries of care for children with laryngomalacia. So here are some of the flow charts from there. I put it in here more for the audience's reference in the future if you want to look at them. But, again, categorizing into mild, moderate, and severe, you can see that categorization was done purely on symptoms, not based on endoscopic appearance. And that kind of goes back to what I was saying previously. So again, when kids have mild laryngomalacia, often we can just manage them expectantly. Clinical follow-up, make sure they're growing and feeding well, make sure their breathing is not getting significantly worse, and just reassure the parents, for the most part, that things are going to get better. Children with moderate laryngomalacia, typically acid suppression. We'll talk about some alternatives in a minute. And then children with severe laryngomalacia typically are going to go for surgery. And then, the graph to the right talks about kind of the feeding evaluation, and we'll talk about that as well in a moment. But many of these children will have signs of dysphagia and aspiration, and we do have to keep that in mind as a condition or a problem that travels along with laryngomalacia. So in my practice, really anyone with any sort of suspicion for laryngomalacia gets a scope. The referring provider took the time to send them to me. Parents took the time to come and take the day from work or travel to come see us. I think that it makes sense, and it's a very low-risk thing to do a quick flexible laryngoscopy in clinic. And part of that, again, goes back to this idea of just having a high index of suspicion. If you think there's any concern that there's an airway disorder, it's worth checking. If possible, I will try to do an endoscopic swallow evaluation during that scope exam, because generally parents who bring their young babies are traveling with some sort of way of feeding them, whether it's the mother's breast or whether it's a bottle. A quick endoscopic swallow evaluation will give information about swallow safety and may help give you a clue about whether a more formal radiologic swallow study is indicated or not. If I use acid suppression, I typically will start with famotidine, 0.5 milligram per kilogram twice a day. That is at the upper end of the dosing range, but I feel like if we're going to take the trouble to treat the child, we may as well start at the top end of the range so we're not wondering whether we're just underdosing if they don't improve. But what I do, which is maybe a little bit strange, I'm not sure how others approach this, is, okay, you start the dosing, what do you do over time? So what I do in most children is I will calculate that 0.5 milligrams per kilogram, prescribe that dose, and then keep that same total milligram dose over time as the child grows. And so functionally the dose in milligrams per kilogram tapers down. And so as the child grows, you get this automatic taper of the dose, and we just see what happens. In most kids, you just sort of gradually taper off over several months. But occasionally you have a worsening of symptoms as they grow. And in that case, you just increase the dose to match their weight in kilograms at that time, and then let it taper off again. I generally do not use proton pump inhibitors or dual acid suppression. I know there are people who favor those approaches. But given that there are some data suggesting that more aggressive acid suppression than H2 blockers can cause gastric bacterial overgrowth, and if the child is refluxing and aspirating, then the risk of pulmonary consequences is actually higher. So I tend not to use those. And there are some data that, particularly there's also dysphagia, that thickening may actually be a better option. And by thickening feeds, we can manage both the dysphagia and the reflux. And there was a study, for instance, a couple of years ago from Boston Children's suggesting that thickening may actually be a better option in some children than anti-reflux medication. That, though, requires the parents to understand and do thickening, be able to have access to thickener. If the mom is breastfeeding, then of course you cannot thicken if they're dry breastfeeding. So there are challenges there. And then in terms of evaluating for a second lesion, I only do that if we're going to the operating room anyway, because my feeling is it's not worth putting a child under anesthesia to look for a second lesion that has not even manifested itself. And if it's something significant, it'll show up, and then we can go check. So when we think about surgical treatments, supraglottoplasty, of course, is the standard operative intervention. We can see here on the top pictures on the left a child in expiration, and then on the right inspiration, you can see the severe dynamic prolapse of the arytenoids causing essentially total supraglottic obstruction. So we go in and open the upper portion of the larynx, and we'll talk about that in a minute, and you end up with the bottom picture, which is how the airway looks on inspiration. It's nice and open, there's no supraglottic obstruction, and things look good. So what are the steps of the operation? Again, this will be familiar to many people, but if there are any trainees in the audience, for instance, typically this is done endoscopically with a suspension laryngoscope. I think it's most easily done with a microscope, so you can operate with both hands, but you can do it with a telescope as well. With a rod telescope. You can do it with an endotracheal tube in place or without. You can see in the picture to the right, there's a tube sitting in the pharynx and providing essentially blow-by oxygenation to the larynx. You can do it with Thrive or high-flow nasal cannula. You can do it with an endotracheal tube right through the larynx and just work around it, and those are all fine. There's lots of different ways to make the actual tissue incisions. I prefer to use cold steel because it's fast and cheap. It doesn't generate, disposable waste as much, and it's very safe. And it's very quick, it's 4 quick cuts. You release the aryepiglottic folds on both sides, you trim the cuneiform corniculate complex on both sides, and you're done. It should take 10 minutes. I try to keep an intact mucosal bridge between each of those 4 incisions to reduce the risk of supraglottic stenosis. And I will typically inject steroid into the 4 incisions as well for the same reason. Other people have used laser, the coblator, microdebrider. I think they're all fine, but they all require more resources and more equipment, and they're slower. Typically for the aryepiglottic fold incisions, I will push on the larynx, just reach around and push the larynx to one side or the other to create some countertension. For the cuneiform and corniculate incisions, I'll use a cup forceps to retract those to create countertension. And then you get some hemostasis with epinephrine pledgets, and then you take some photographs and you're done. In terms of the postoperative recovery, typically I will admit these patients overnight, either to the ICU or the general ward, depending on their age and overall clinical status. I think it's really important to educate parents and anesthesiologists and ICU doctors and everybody that the child will still have some stridor. So, when we think about the goal of surgical treatment here, it is not to entirely eliminate the laryngomalacia. It's very tempting to aim for that. But if we remove that much tissue, the risk of dysphagia and worsening dysphagia, I think, is higher. What we need to do, I think, is to open the airway just enough that the child can outgrow the rest of the laryngomalacia because they're able to feed and breathe better. So it's important to warn people to expect residual stridor afterwards. So in terms of the breathing outcomes, generally supraglottoplasty is very effective. However, it is really important to know that the success rate is lower when there are comorbidities. particularly neurologic disease and certain syndromic diagnoses. And I want to just highlight CHARGE really quickly, because CHARGE patients are notorious for having really tall arytenoids. It's very tempting to go trim them, but it's often really unsatisfactory. So laryngomalacia and CHARGE, there's a very high prevalence, particularly in children with the formal CHD7 mutation. Laryngomalacia can be very severe in these kids and often associated with lower airway tracheomalacia, bronchomalacia. But in addition to these tall arytenoids, these kids will often have short vocal folds. They may have salivary pooling in their larynx. They have discoordinated laryngeal movements. And between all of this and their cranial nerve problems, they tend to have significant dysphagia. And supraglottoplasty in these kids tends to be much less effective in improving the breathing, and it may worsen aspiration. And you can see here, these are some examples from an older paper by Dave White and colleagues that shows what these arytenoids look like, and it's very tempting to go and aggressively trim them. But I would strongly recommend against that. A little bit of trimming may make a minor difference, but this is a low yield thing in these CHARGE children, I think. What about swallowing? So children who have dysphagia may actually improve with supraglottoplasty, and there's evidence in literature for that. But I think that excessively aggressive or careless supraglottoplasty can absolutely worsen dysphagia. That said, if you're conservative and careful about it, it's a rare complication. But I do think that it's fairly common to see a transient postoperative worsening of swallow due to pain and sensation change. And as the mucosa heals, that tends to recover. But it's important to warn parents to expect that. If there are persistent symptoms, then again, that IPOG guideline statement has some guidance there, but it involves, basically looking for other causes, sleep studies, MRIs, and so on, investigating based on your clinical suspicion. So with that, I'll wrap up. My email and phone number are here. Please feel free to get in touch anytime, and I'll turn it over to the panel.
Thank you, Dr. Balakrishnan.